of the clinical tour, and we are honored to have their guest, Professor Pascual, with us today. And it is the moment of to continue the immune suppressive aspects. So now it is my pleasure and honor to introduce Professor Ayman, the Chief of the Health and Transplantation Unit at Urology and Nephro Center. He will speak about one of the most important issues in immune suppression, which is induction therapy in kidney transplantation.
Why we need induction therapy? For several reasons. To decrease rejection rate and hence to decrease the instance of graft loss, to lower the instance of delayed graft function, to avoid corticosteroids, and to avoid or delay the introduction of CNI inhibitors, and as Professor Pascual stated this morning, to transplant high-risk patients and maybe to induce tolerance. Induction therapy may be depleting or non-depleting. The depleting agents are either alumizumab or camber-1H targeting CD52 and or thymoglobulin, which is a polyclonal antibody. Both can be used for either induction or treatment of rejection, and they need to the patient should be pre-medicated in view of the adverse events that frequently occurs with the administration, so monitoring of the patient is essential. On the other hand, the non-depleting interleukin-2 receptor antagonist stimulate starting CD25 is used only for induction, and the cytokine release and hyperactivity is rare, so no monitoring is needed. There are three eras over which the evolution of induction therapy. The first era was from mid-80s to 1993, where this is an era of low induction, and they used anti-leukocyte globulin prototype 3. Then from mid-80s to 2002, there was high induction therapy with basilizumab, and then from 2003, the introduction of the recent depleting agent in the form of ATG or alumizumab. On what base we select the induction therapy for patients? Again, like was stated by Professor Pascual this morning, the risk stratification is very important. Either from no induction in patients with low risk to induction with the depleting agent in patients with high risk. By high risk we mean increased number of HLA mismatches, the high pan-reactive antibodies, the blood grouping capabilities, etc. This is algorithm, as stated this morning also, that every center can put its own algorithm, and this is a Brazilian algorithm. They classify patients either to have PRA below 30 if they are identical, haploidentical, and they need no induction, or if they are non-identical, they use basilizumab in an era, then they shift it to thymoglobulin. But if the vanillin antibody is more than 30, they go for thymoglobulin from the start. What did we learn from the international guidelines regarding induction therapy? Of course, the famous KD2 guidelines, which was published in 2009, stated that it's recommended that interleukin-2 receptor antibodies should be the first line of induction therapy, and to reserve the lymphocyte-depleting agent for the high-risk patients. Also, the European Association of Urology guidelines in 2010 stated that the use of interleukin-2 receptor antibodies for preventive rejection is effective and safe, and effectively reduce the incidence of acute rejection and enabling C9 steroid-sparing regimens. And the formal evidence for improved patient graft survival is lacking through recent large clinical trials. And for the T-cell depleting agent, they advise the use of T-cell depleting agents that has not been associated with improved the outcome in overall population, and they should be routinely used in high-risk patients, and in such induction therapy there is increased risk of post-infection and cancer. The UK Renal Association guidelines again stated the same like PDU, that in patients with low-risk patients that we should go for interleukin-2 receptor antagonists, and in high-risk patients the T-cell depleting agents, and induction of T-cell depleting agent also be useful for lower immunological risk patients and to allow BCMI and steroid-free regimens. The CARI guidelines of Australia stated also the same recommendation, that interleukin-2 receptors is the first line of induction and T-cell depleting agents for cases with high risk. So, if there is any impact of induction therapy after all on the patient and the graft survival, actually there is constant improvement reached. One of the cons, the use criteria. The use criteria showed that a correlation between the incidence of acute rejection and graft survival. This was evident in different races. If we look for the best graft survival was white with no rejection, followed by blacks with no rejection, then the white with rejection, and the worst was blacks with rejection. And they showed clearly that induction with depleting agents showed superior graft survival than bezaliximab, than no induction. And they concluded that induction with suppression improved graft and patient outcome for most organ transplant, and depleting agents, especially in combination with steroids, seems to be more effective than the interleukin-2 receptor antagonists. Another study which studied the survival intervals over 10 years showed clearly that the graft function over 10 years was superior in the group which received the ATG induction. On the other hand, another German study in whom patients who received bezaliximab for more and followed up for more than 10 years, they showed no beneficial effect of the induction therapy with bezaliximab for 10 years. And another Indian study over 7 years, no beneficial effect of induction, and the conclusion was clear that bezaliximab induction does not significantly increase graft survival at 5 years post-transplant. However, the benefit in terms of significant reduction of early acute rejection as well as reduction of severity of acute rejection was reconfirmed. What did we learn from our Egyptian live donor kidney transplant recipients? Actually, Professor Ashraf stated this clearly this morning. I'm going to show you again some of these studies. This is the first randomized studies which was carried between 1998 and 1999. This is work for our dear colleague Professor Hussein Shubesha and his MD thesis. He randomized the patient in two groups, 50 group each, bezaliximab induction in one group and the other group with no induction, and both groups received steroid cyclosporine and azathioprine. What did he found? That at 5 years, although the number of patients who experienced acute rejection was significantly less in the induction group, and also the severity of rejection was less among this group, and the cumulative doses of steroid were less. However, the patient and graft survival were more or less the same and comparable. So we concluded, like what's concluded internationally, that the rituximab induction significantly reduced the incidence of acute rejection, and however, its beneficial long-term effect on graft and patient survival are not yet evident. When we followed these patients for 10 years, we got the same conclusion: no significant impact on both graft and patient survival. When we tried the other interleukin-2 receptor antagonist, tacrolimus, we got the same over 10 years, 8 years follow-up. This is another controlled randomized trial using bolus ATG 9 mg pre-operative, and we found that what we get from the tacrolimus study, number of patients who experience acute rejection is less, the severity of rejection is less, and the cumulative dose of steroid in the induction group, however, the patient and graft survival were comparable. When we tried in 2006 the alumtizumab preconditioning aiming for steroid-free and calcium-free regimen, we conducted a pilot study on 20 patients receiving single dose of alumtizumab pre-operative 30 mg, and the patient were kept steroid-free on tacrolimus and MMF for 2 months, and then after 2 months they were evaluated. If they are rejection-free and the protocol biopsy showed no ongoing subclinical rejection, no proteinuria, those patients were straight away shifted to sirolimus and MMF. What we found that 5 patients developed acute rejection. All of them were borderline rejections. All of them responded very nice to steroid pulses, and the majority occurred in the first 2 months, and all the 3 patients were kept on steroids and triple therapy. The hardest of this study that we have 17 patients, 85% steroid-free and 75% steroid and CNI-free, and they are enjoying a good graft function. All these experience in the among our Egyptian patients were nicely summarized and comprehensively illustrated in this review by our dean colleagues, Dr. So now the question: induction therapy, renal transplantation, is it the path to prolonged survival? I think from the international guidelines and from our experience, it is not. So the take-home message from my talk is: interleukin-2 receptor antagonist induction, although significantly reduce antibody rejection, however, it has no impact on graft and patient survival, even in the tacrolimus-based immunosuppression. The induction therapy is helpful to both applying minimization to suppressive protocols, and it's mandatory in cases with delayed graft function, and it's mandatory in high-risk patients, and lymphocyte-depleting agents rather than interleukin-2 receptor antagonists are prepared for kidney transplant recipients at high risk. Thank you.
Thank you very much, Professor Ayman, for this comprehensive presentation, and I think we have time for questions. Questions?
Another question. In the setting of your usually low-risk patient, what is the use of hemoglobin here? Do you have any indication?
No. In the low, in the cases with the, only in cases with the radial function, with ATF, yes, in DGF, we used to stop calcium for 7 to 8 days, 7 days, and cover with time. This is the only indication in those patients.
Thank you.